Well, I'm back. Sorry about that. And Carly's great, so if you have any questions, she can help you. I'm a sports medicine fellowship trained orthopedist, but really my practice has morphed into a cradle to grave knee practice. So I don't take care of anything but knee injuries and knee problems. And I've really been doing exclusively that since 2002. And as I thought about what to talk about today, because I've been in front of this group a few times, and it's always kind of a struggle to figure out what I want to talk about. Really, we haven't been together for 3 years, so I want to just briefly go through some of the new things that we may have touched on back in 2019, and just kind of give a little update on where we are, some of the new things that are happening, and then hopefully answer any questions you may have. So this is disclosures, nothing to reveal. So really what's new and not so new about post-COVID-19. And so I just want to talk briefly about 4 different things. One, meniscal root repairs. I think in 2019 we were just getting into actively repairing them on a routine basis when we identified them. And we'll talk about what those are and why they're different. We're going to talk about primary repair of ACLs. We're going to mention a little bit, just briefly, talk about robotic total knee replacements. And then a real quick summary. I think it might have been my last talk at this symposium. We talked in detail about Ortho Biologics and talk about how things have changed and not changed around Ortho Biologics. So first, meniscal root repairs. So meniscal root repairs, this is a picture here on the right where you can see the meniscus. This is the meniscus tissue right here, and it's disrupted. It's supposed to be or is attached to the bone. And the best way to think about a meniscal root and what a root is, so if you look at the meniscus, so first of all, for those who aren't as familiar with knee anatomy, the meniscus are these little C-shaped cartilages that go between your thigh bone and your shin bone. And they have little attachments that go around the outside that keep them attached to the shin bone or the tibia, but they're spot welded to the bone in 2 areas, right here in the back of the knee and right up here in the front. And we call those the meniscal root. So the meniscal root is basically where it's anchored to the bone. So meniscal root tears are in particular very evil. So we have a lot of meniscal tears that we deal with on a regular basis, but the majority of those, let's go back, the majority of those are in the substance of the meniscus, either on the periphery where we can repair them with stitches, or more on the thinner inner part where we can trim part of it out, and those patients tend to do well with really a pretty quick recovery. Meniscal root tears are much more evil because if you have a meniscal root tear, if you come in and see me with a run-of-the-mill degenerative medial meniscal tear and it's not bothering you much, we probably won't do anything. I mean, there's no harm in not doing anything. There's no urgency in dealing with it. And if it's minimally symptomatic, it's certainly something that you can live with really no detrimental effect other than the fact that you lost function of a small part of your meniscus. So meniscal roots are different. When you have a meniscal root tear, you lose 100% the functioning of your medial meniscus, or lateral meniscus, but 90% of these or more are on the medial or inside part of the knee. So these are very evil. I've seen patients go from having essentially a normal knee to being ready for a total knee in a year or a year and a half when they have a meniscal root tear. They're bad. These are bad tears. So this jump to how we repair these and what's different about it. So we have to find a way to attach the meniscal root back to the bone and to try to get it to heal. And the way we do that is we basically drill a tunnel from the front of the tibia back to where it's supposed to attach. And it's a small tunnel, but it's about a 4 millimeter tunnel that runs from the front of the tibia back to the back of the knee. And that presents challenges in and of itself to get an accurately placed tunnel back to that portion of the knee. And then we put sutures through that part of the meniscus, retrieve those sutures through the tunnel, and then fix them down on the tibia. So that pulls that meniscus down into this little socket that we've created right there. So that's what a meniscal root repair is. Here's what they look like arthroscopically. We usually put 2 big sutures in, and you can see that it's pulled it right back down. So if you look at how this is pulled off the bone and how this is now attached, that's how you want to see it. And they're pretty good healers. They're not perfect healers. One of the bad things about meniscal root repairs is it's even more important that we limit their weight bearing for about a month to try to get these to heal. So I rehabilitate my meniscal root repairs completely different than most of my other meniscal repairs. Most of my other meniscal repairs, I'll let them weight bear pretty early. So what questions do we need to ask about meniscal root repairs? Well, why do we perform them? Like we talked about, really we're trying to restore the integrity of the meniscus so that we reduce stress to the covering or the articular cartilage that wears away when you develop arthritis. So we're trying to keep this knee from turning into this knee. Now, one thing to think about too, and the reason that meniscal roots are so evil is there's this thing called extrusion. And extrusion refers to a situation where the meniscus is supposed to be setting on top of the tibia. And when you lose your attachment in the back and you continue to weight bear, it's almost like the meniscus gets pushed or squirted out the edge. And so normally you should have a meniscus that sets over this tibia, and if you weight bear for very long and it's not attached correctly, that meniscus will become extruded. And if it's there for very long, I can't really give you an answer on how long that is, but if it's there for very long, it becomes almost stuck there. And so extruded meniscus that you see on MRI scans tell us that they've probably had this meniscal root tear for a while. So does meniscal extrusion limit the effectiveness of root repairs? The answer is probably yes, but these are the things that we're starting to learn and trying to figure out as we go through this process of repairing meniscal roots. Do we need to try to mobilize the ones that are extruded? The hard part is when you're repairing a root, you know which ones are extruded, you can see it, but it's hard to really evaluate how much you're reducing or you're bringing that meniscus back into the joint when you repair the root. And that's why they're so nice if you can catch these early. The natural history of this, before root tears, if a patient came in to see me and they said, hey, I was walking over a curb and I felt a pop in the back of my knee swelled up and now I'm pretty miserable, I'd say, let's watch it for a while. We may get an MRI scan. Sometimes show a meniscal root tear. Sometimes we would miss it because we weren't really looking for them at that point. And then your knee tends to get better. And in a lot of those patients, we wouldn't get an MRI scan at the beginning at all. We would just see if they got better. Now if someone comes in and says, I felt a pop in the back of my knee, I'm miserable, I really dislike deep flexion, I'm MRIing that patient almost immediately because I don't want to miss a meniscal root tear and then have them show up a year later with a knee that's wearing out. So, in summary, we're really attempting to save the knee when we're dealing with meniscal repairs and meniscal root tears. And maybe that's a little over dramatic, but it's not far off. So we're trying to keep this from developing and for patients to end up with x-rays that look like this. So why would we not repair a root if it is in existence there or if we've diagnosed a patient with a root? And this is something I tell every patient that I'm seeing with a root tear is, one, occasionally we'll get in there and the MRI lied. It's not a true root tear, although that's becoming pretty rare in today's world. Our radiologist and my experience with it and those who do a lot of these are getting pretty good at identifying these. Sometimes you get in there, and this doesn't happen very often, but occasionally the tissue isn't good enough for the sutures to hold the meniscus. So if your meniscal quality is real poor, and that's pretty rare. This is a pretty robust part of the meniscus, so that's pretty rare as well. The most common reason that I won't repair an existing root tear is because they already have significant exposed bone. In other words, they already have an arthritic knee and the knee is already in trouble. So I'm not going to put them through pretty significant rehabilitation and limitations on crutches for 4 or 5 weeks if it's not going to do them much good. Meniscal root repair summary. It improves meniscal symptoms. A lot of patients who come in after a couple months of being miserable, this really makes them feel better pretty quickly. It's pretty technically challenging. When you're first starting to do these, they can take a while because it's a really tight space in the back and you're trying to get sutures in the right place, get the tunnels in the right place. So it's a pretty challenging procedure. Unknown how and if it limits progression of osteoarthritis. I'm going to be surprised if it doesn't. I think it certainly keeps a lot of patients from crashing and burning very quickly. But what does it mean 10 years, 15 years down the road? I think only time will tell in that regard. How do we deal with meniscal extrusion? We're working on it. Hopefully here in a year or two I'll be able to give you more information on that. And we still have a lot to learn about meniscal root repairs. So second topic that I think we just started talking about in 2019 was there's a renewed interest in meniscal repairs. In other words, when a patient tears an ACL and they're active enough to require a fix, so to speak, we usually do a reconstruction, which means we replace it with a new ligament. And that's still what we do predominantly, but meniscal or ACL repairs have become a little more commonplace, and they probably have a role for a select group. And I just wanted to talk briefly and touch base about meniscal repairs. Reconstruction is still more predictable than a repair. Why is that? So if we look, this is a picture on the skipping ahead. This is one that was repaired, and you can see we have sutures that are pulling it back up to the bone, but you see that this tissue quality is really pretty good. In other words, it got pulled right off the bone. Well, the majority of meniscal tears don't have that good quality nature to them. Sometimes it looks like a bomb went off in there, and it almost looks like it's just a whole bunch of spaghetti. And repairing that tissue is it's almost impossible. And we're asking that tissue to heal and to be held together by sutures. And again, it's like the meniscal root repair. That tissue's just not adequate to hold the sutures and for us to expect it to heal. It has a singular vascular supply for the most part, and that is disrupted when it's torn. Tissue quality for the majority of ACL tears is pretty poor, and the repair can again be pretty technically difficult, particularly if the tissue is bad. Reconstruction, this is a picture of a reconstructed ligament. It just tends to be more predictable. The graft source, or what we're using, is much more predictable than a repair can be. Now, reconstruction disadvantages. Why do we think about repairing in some certain circumstances? One, you're going to take tissue from somewhere unless you're using an allograft. And allografts are less predictable as far as longevity and durability with young athletes, so we don't use them in young athletes. But you're going to have some morbidity. There's some trauma to harvesting your hamstrings. There's some trauma to harvesting part of your patellar tendon, and certainly those things can linger for a while. It's still a technically challenging procedure. I mean, I tell patients, hey, back in the 90s, there was a lot of bad ACL surgery done. I got to be honest, there's still a lot of bad ACL surgery that's done. And I think it's much more difficult than we give it credit sometimes to get the tunnels in the right place, to get the graft appropriately tensioned, to make sure it's not impinging, and then to rehab these patients optimally. Successful outcomes require this process of ligamentization, and this is something that's different. So we usually use a tendon to replace a torn ACL, which is a ligament. And tendons and ligaments, for the most part, are made out of the same thing, but in different distributions. So if you look at the different types of collagen, and you look at it as far as elastin, they all have kind of the same structure, but in totally different distributions, and they look totally different under a microscope. That's called a crimp pattern. And we're asking that tendon that we put in to turn into a ligament. And the amazing thing is your body will do that for you. It will turn that tendon into a ligament, but it takes time. And that's why we see athletes who re-injure. There's lots of reasons for failures of ACL reconstructions, but part of it is this process of ligamentization takes up to 18 months or more. Well, we can't hold athletes out for 18 months, but it takes a long time. ACL Repair Advantage, it's minimally, morbidity rate is low because we're repairing something that was already there. We're not stealing something to repair it. We can do it through the scope, and there's no need for ligamentization. Disadvantages of a repair: it's unpredictable in its healing. We're often dealing with poor tissue. It's technically challenged to get a good repair, and then we have to protect their rehabilitation much more than we do with a reconstruction. Again, these patients tend to be non-weight bearing for a while. So who do I think is the ideal ACL repair patient? I think young patients who have open growth plates and they demonstrate that they need their ACL fixed. We really have two options. We can either early on do a repair, and you need to make this decision pretty early, because you can't go in 3 months later or 5 months later and do a repair. You need to get to that tissue relatively early. Or you can do what we call an epiphyseal sparing procedure, where we don't drill across the growth plates. The problem with that is epiphyseal sparing procedures have a much higher failure rate. In some reports, anywhere between 25 to 35% failure rate. And part of it's because it's a procedure that's hard to do. Part of it's also the age group. Young patients that tear ACLs tend to have a reason for tearing them. They have poor proprioception, poor alignment, some other reason. So the failure rate's going to be higher. So I think for a lot of young patients, if they have good tissue to repair, that's a really reasonable option. We've had pretty good success with, not perfect, but pretty good success with repairing ACL tears in the 8, 9, 10, 11 age group. Older patients wanting to avoid reconstruction, I think this is also a reasonable option for them. As we get older, we tend to tolerate things a little less. At least that's my case. And I probably, even at my age, I probably wouldn't want a repair. I'd probably still want a reconstruction, but it's an option for some patients. You need healthy ACL tissue. So it really needs to be torn off the femur or off the tibia. Mid-substance tears, really, you can repair them, but they're not going to do very well. Here's a picture. This is an ACL. Here's the stump that should be attached back there, but you can see how healthy this tissue is right here. This would be one that you would consider repairing. In fact, I did repair this one. Okay, so let's talk briefly about robotic total knee replacement. That's something that's become much more popular and is probably on the rise. And really, what is robotic total knee replacement? Because there's robotics in a lot of areas of medicine, and this is a little different. It's really just a way of accurately measuring alignment, rotation, soft tissue balance before we make our bony cuts. So all the things that we used to evaluate intraoperative by feel, we have some guides and some things that we did manually. Now we're trying to measure those things before we make our bony cuts and to evaluate that soft tissue envelope. It's an incredible tool. I mean, I've been using it for probably a year and a half, and quite frankly, I think it's incredibly valuable. It gives me information early in the case and helps me adjust my cuts and my rotations instead of doing the best guesstimate that we can, making those cuts and then making adjustments with soft tissue work. Here's a picture of the ROSA, which happens to be, there's several on the market. This is the outfit that's in the operating room. Here's the screen, sorry about that. Here's the screen that we do all of our work on. Here's the cutting guides and all the software's in here. So you see this camera up here? You triangulate everything. So when we're doing this, we put sensors on the tibia, sensors on the tibia, sensors on the femur, and then you have that camera off in space here. And so you can move the knee around, and you've marked 32 different landmarks. And so we have incredible accuracy on alignment. We know where our hip axis of rotation is, the center of the knee, the ankle, all those things are marked. So I won't believe, this would be a whole talk in and of itself. This is just a picture of the screen that gives us some information. Here's our soft tissue balances. I mean, these are all things that give it to us in the 0.5 millimeter instead of me going, hey, I think that looks pretty good. Here's another screen that again is telling us what our cuts are going to be. It's telling us what our balances are going to be if we make those cuts that in this orientation. So, and I won't belabor that. I'll be happy to answer any questions about that, but we could talk about that for hours. So Ortho Biologics, I'll go through this very quickly. I talked about this a few years ago, and I'm still not an anti-orthobiologic person. I think there's lots of challenges in this arena. There's still limited evidence of regenerative potential, and when I say regenerative potential, I'm talking specifically about regrowth of cartilage. There's certainly limited evidence of that. The FDA limits our ability to enhance cell counts, and what that means is the FDA won't let us culture stem cells. Most of the studies around osteoarthritis show that if you can deliver 20 million stem cells or more to a patient, they have a better subjective or symptomatic relief, okay? Now, if you get a bone marrow aspirate, you're probably getting somewhere around 200,000 to 300,000, not 20 million stem cells. Okay, so you're getting a very small fraction of what most of the studies that are performed, quite frankly, in Europe and Asia mostly, demonstrate good symptomatic relief. But the reason for this is because the FDA won't let us culture stem cells. Stem cells are easy to culture. They want to grow. They want to replicate. But they consider this modifying cells. So as of now, they will not allow us to enhance stem cell counts. it remains more of a symptom modifier than a disease modifier. There's probably some exceptions to that, chronic tendinopathies, but it certainly hasn't been demonstrated to regrow cartilage. And I think the bottom line with Ortho Biologics is we need to identify what our potential uses and appropriate treatment timing is. I think there's going to be a greater value in using it in patients who have had meniscal repairs, and the timing where we should use that. There's no question that in the equine vet world, horses who have surgery, or race horses that have surgery for what they call chip fractures, which in my mind is just osteochondral injuries to the articular cartilage or arthritis, traumatic arthritis, do better if they receive 20 million or more stem cells starting at around 5 weeks after their surgery. They return to the track more consistently. And the nice thing about that is there's no placebo effect with racehorses. So the question is, where do we use these? I mean, and again, we could go into what happens when you traumatize a joint and the macrophage infiltration and the changes in your cytokines and your growth factors, and how that can lead to other problems and lead to a 10 times higher rate of osteoarthritis as life goes on. But we really need to figure out where we use these, how we use them, and I think right now we're not doing a good job at figuring that out. So finally, as my time runs out, I want to say thank you, and are there any questions? So the question is what age range do we see meniscal root tears? It tends to be more of a middle age injury. I have seen a 14-year-old, he's at the trampoline park, which is very good for orthopedic business, by the way. But for the most part, meniscal root tears are showing up mostly in 40 and 50, 60-year-olds. I used to have kind of a hard cutoff, if you were over 65, wasn't too aggressive about repairing meniscal roots. And as I've done these, I'm way more aggressive. Because there's a lot of people in their mid-70s that show up with meniscal root tears, and they don't have much arthritis. And they do well with this. I mean, they do as well as the 45-year-olds that I repair, but it's a middle-aged and above injury. Yes. So the question is there anything on physical exam that would differentiate a root tear from a normal meniscus? And that's a great question. Yes, I think there is. So one, I think your history can be very helpful. Not all, but a lot of patients who come in with meniscal root tears will come in and have a history that they were doing something trivial and they felt a pop in the back of their knee. And so I used to say, there's not much bad in the back of your knee. It'll all get better. And truthfully, it will, but these are ugly tears. Most of these patients will have a significant effusion, so they got a swollen knee. And the hallmark sign is it's very irritable if they do deep flexion. So patients that have root tears, you try to do this to them, man, that kills them. I mean, just simple flexion deep into that range of motion. If it's not the normal, hey, this is really tight because I have a swollen knee, it's this hurts in the back of my knee. So I think that's the hallmark sign of it. Bottom line is if a patient comes in to see you with a history of that pop, I MRI them very quickly. I don't want to miss meniscal root tears. One last question, yes. Say that again. Oh. Yeah, we do. So the question is when I say very quickly, what do I mean by very quickly with root tears? Really, you probably have a few months. So we don't do these urgently, and If patients come in, they don't usually come in a day after they have this happen. It's usually a few weeks. So I'll be aggressive about getting an MRI scan in the next week or so. Then if I see them back and they have a meniscal root tear, I'll still let them schedule it around their life, so to speak. Do I want to wait 6 months? No. Is a month or so okay? Yes. Yeah. So we'll I hope that answered that question. So it's not like having a fracture or something of that, or a tendon rupture, but it's probably somewhere in between. You don't want to wait 6 months. You don't want to wait a year, because sometimes some damage will occur in that time period. Thank you for being here, and hope to see all of you next year.